I'm going to make it quick. So that patient was referred. This is suspected cardiac anomaly. So, and this is where we're going to put it all together. So remember, we talked about the position of the heart within the chest. So the situs, here we have the baby in the cephalic position. We can see the heart, if it's cephalic, completely in the right chest. So this is significant dextral position. So then we think about dextral position. So this is something that usually is induced from outside. So it's either diaphragmatic hernia or some primary lung disease, such as the CPAM or the bronchopulmonary sequestration. So then we look at the four-chamber view. What we can see here, we can see that little circular structure where at the lateral aspect of the mitral annulus. This is something that very indicative of the persistent LSVC, and at the same time we can see perfectly normal drainage of the left pulmonary vein to the left atrium. Well, so can you see any masses in this lung? No, we were able to see on the situs view in the upper abdominal level that the stomach is in there and the liver in the correct position. So you may ask, well, the angle of the collar box, the size of the collar box is too narrow. You're probably not catching something from the right lung. Well, let's open up, even though we want to keep it narrow, so you still cannot see any venous return from this smaller portion of the lung on the right, but from the left we have a perfectly normal blood flow in these pulmonary veins. So here you need to stop for a second and think what type of pathology you are dealing with. And this is the classic presentation of the hypoplasia of the right lung, and this corresponds to the Scimitar syndrome. So now you're on a mission to find where that pulmonary veins are connected, and for sure, if you look good enough, you will be able to visualize that inferior segment of the lung, the vessel that's in here, draining directly to the IVC, and here you can see the classic blood flow typical for the pulmonary veins. I think that the pulmonary veins, it was the theme of today's of this course, and I hope that we all gonna learn how to pick not just the total anomalous pulmonary venous return, but the partial as well. So for Scimitar syndrome babies, it's very common to have the concomitant cardiac malformation. So this baby had a VSD, perimembranous, subaortic, and also we can see that 3-vessel and trachea view, that extra vessel, and in this case we know for sure it's the persistent LSVC. Baby also had the abnormality of the spine, neck, enlargement of the jugular pockets or lymphatic nodes, and showed growth problems over time and had 2-vessel umbilical cord, and that was the diagnosis. And the postnatal findings were consistent with Scimitar. I let you to decide if it looks like the Turkish sword or not. I think that our radiologists have a great sense of imagination, but I think what's important for us that we are very diligent about what we are looking at. We are very strategic, systematic, and then we can pick up those rare malformations. I would like to thank you for your attention. It was a pleasure to be here, and I hope to see you in the future. Thank you very much.
So I'm going to just go through a couple quick cases to get us wrapped up, nothing too complicated. So this is a patient that came in for a fetal echo with us. She came in at 29 weeks, referred for echo for a 2-vessel cord, small stomach, and polyhydramnios. So there was concern that there was a tracheoesophageal fistula. They had already cleared the heart, but they thought it'd be reasonable to take a closer look with fetal echo. So this was the initial imaging for her. So it was a breech presentation, situs correct, and you can tell that she did have a higher BMI, and we definitely had some issues with rib shadowing. And you kind of get a sense of the stomach. It's present, but a little bit small. This is still kind of working at it, so looks like we have 4 chambers, reasonable proportions, but again, we've got that rib shadowing that's coming over our left atrium, so can't really quite see back there. So now kind of reposition and get a little bit of a better picture here. So we're thinking still a reasonable 4-chamber view. Left ventricles on the left, it's a morphologic left ventricle, morphologic right ventricle. Right atrium maybe a little bit larger than the left atrium, and kind of take a look at this left atrium and what are we not seeing? Pulmonary veins, correct. So if you're going to take something home, it's definitely going to be knowing how to look for these pulmonary veins, right? Okay, so here's our descending aorta, here's our left atrial wall, so maybe a little bit of an increased space, but not quite seeing something in this plane. So repositioning again here, and now we can see our venous confluence behind the heart. So keep in mind, actually this came from an MFM practice that had previously already cleared the 4-chamber and the outflow tract. So just how important it is to make sure that you're looking carefully behind the left atrium. Color Doppler, we talked about, so we can see that these pulmonary veins or this venous confluence is really abutting the back wall of the left atrium, but not going into it. So the next question is, where are these veins going? Right, so we know that they can return above the heart, coming behind into this confluence, and then draining through a vertical vein up, and then more commonly draining into the innominate and into the SVC. Also can go below the heart. So kind of our next step here, and what I wanted to feature here, is how we figure it out, right? So we can see that the pulmonary veins are abnormal. But where do we go from here? So I'm going to go above the heart first, and this 3-vessel trachea view can be really helpful for you. So if you have extravenous drainage going above the heart, then what happens? You tend to get a dilated SVC. More flow will cause these structures to become dilated. So here we have our PA, our aorta, and our normally sized SVC. So not seeing anything in this plane. We're then going to start to look below the heart, and we saw some images yesterday where we saw some extra vessels in the plane of the abdominal circumference, which certainly can be a clue, but depending on if the venous drainage is going just below the diaphragm, then you might not see that in the plane of the abdominal circumference. So we can't tell without color Doppler. Starting to look here, and when we turn on our color Doppler, this is really going to give us the answer. So keep in mind, any venous drainage that you see going away from the heart in this plane is going to be abnormal. So this red flow here is showing us our vertical vein kind of traversing the diaphragm and looks like it's coming in just at the level of the hepatic veins as they reach into the IVC, which is a common location. Okay, and this is labeled for you. So remember, Doppler, really important. So if they had Dopplered the pulmonary veins when these were looked at initially, then this abnormality would have been caught. But here is the Doppler profile here. If they go below the diaphragm, they pretty much are universally going to be obstructed. So we see this monophasic low velocity profile. And then when we do the Doppler, at the site of insertion here, it's even a little bit more higher velocity. So as we heard Dr. Moon-Grady tell us yesterday, it doesn't really matter what the velocity is. If you see this flow pattern, it's going to be obstructed, in particular if it's below the diaphragm. So this is just a sweep showing us the confluence going down. And if we work at it here, so we're not quite at the level of the stomach, but we can see that extra vessel there below the diaphragm. So, and you can see what a difference the image optimization and fetal positioning can do from where we started to where we ended up with to make this diagnosis. So the outcome confirmed TAPVR with that drainage, pretty much what we saw, drainage going into the hepatic vein with severe obstruction, had repair diet of life 1, did indeed have a TE fistula and esophageal atresia, and also had segmentation anomalies in the sacrum. So is this a VACTERL? So this baby underwent genetic testing and did indeed reveal a very rare microdeletion syndrome, 1Q21.1, which is, again, very rare, but associated with cardiac anomalies, urinary anomalies, as well as various levels of neurodevelopmental delay. Can't say that fast. Okay, so one more quick case for you. So this is another patient that came in at 21 weeks and was referred for an abnormal 3-vessel view. So the aorta was the same size as the SVC. They thought at the plane of the 3-vessel view. Didn't see any other additional anomalies. So this is what the 3-vessel view looked like here. So again, remember the SVC should be smaller than the aorta. So it looked like the aorta was about the same size, maybe a little bit smaller than the PA, but the SVC should be smaller than the aorta, which it was not. And you kind of, as you come higher up into the left brachiocephalic vein, you can see indeed it does look large. When we looked in the bicaval plane, this is another way to look at it, so it should be also similar in size to the IVC, and we can see it was actually quite dilated and prominent here. And if we look, this also measured. There we go. So how about the pulmonary veins here? Is this a case of supracardiac TAPBR? So in this case, looked very carefully at the pulmonary veins, looked very carefully at the rest of the cardiac anatomy, and couldn't find a reason for why this SVC was so dilated. So in this particular case, this was a very astute sonographer who knew to then go up to the brain, right? Because the extra flow needs to be coming from somewhere. And you can see that the grayscale imaging does not reveal our diagnosis there. You need to put on the color Doppler. And here we could see that this was a vein of Galen aneurysm. And we can see showing the drainage there. And then a nice 3D picture just didn't help us in the diagnosis, but did make a pretty picture. So other things to think about when we see vein of Galen, it is associated with coarctation of the aorta because there is preferential flow, carotid flow here. So if you can be susceptible to the no flow, no growth phenomenon, and also is associated with sinus venosus ASDs because of that increased flow into the SVC. So that's all I have for you. Thank you very much. It's been an honor to be a part of this conference.